Yeah, thank you very much for the invitation. It's for me a great pleasure. Since many years I'm following the presentations of SHAPE and always wanted to be part of the SHAPE community, and I thank very much all the members that they choose me as part of the SHAPE initiative. And I want to go with you to some of the results we have in Europe. The CT was not in this way pushed forward as we see here, mainly because the radiologists are owning the CTs, and that is a disadvantage in my feeling. When we look to the number of people dying from coronary heart disease, then you see that over the time in younger and older people the decline is very strong. Here in the study from Sweden, and this is true for women and men, and the older and the younger people. But most important is when you look to the people who die from myocardial infarction, that 60 to 80% of those dying, as you see here, are dying out of the hospital. That is the biggest challenge, and that was always a motivation for me to look into this problem, because I think each myocardial infarction in EDS is a disaster for prevention. As we had heard, we can use different scores, Framingham, PROCAM, and the European Heart Score, and this is called in Europe the first step of risk assessment. And risk stratification is based on categorizing then people into low, high, and very high risk. The problem I see in all these courses that they have different algorithms, and the results are very different when you just check one patient. And in addition, you have different cutoff values. The heart score is using a cutoff of 5% as high risk. And you also have heard previously that 20% is high risk when you use Framingham or PROCAM. So this is something which is not good for the general physician, because he is confused, and doesn't know how really to handle all the things. So when we have now done this categorization, it is suggested to go to low, high, and middle to further detection of signs of subclinical atherosclerosis in the way when we have intermediate risk. With low and high risk, we know what to do. In our heart 6 of recall study, which is, and we were happy to see this and we didn't know it, it was really running parallel to MESA. We started at the same time, we initiated at the same time, we published the design at the same year, and we have 4,814 and MESA 6,814 also. So there is a very nice overlap, and we work together intensively. But when we take Framingham risk in our 5-year observation event rate, then you see it is able to differentiate those with the different categories, and this is, as you see, highly significant. So the event rate 5.8% in the high-risk group. But when you calculate it for 10 years, you see you're not coming to 20%. As usually is the cutoff value for high risk, and that is the paradox in Europe, that the threshold is twofold lower. In the 6 of recall study, we saw that 30%, roughly 1/3 of men is in low, intermediate, and high risk. In women it's much different, 71% in low and only 9% in high risk category, and I will come to this later back. When you now think about how to identify those with disease and how I can most early see changes of the arteries, I like this image by myself very much, because it demonstrates to you in the development of atherosclerosis that from the non-invasive tests, the direct imaging of coronaries is only done with CT. Other tests for the coronary subclinical arteriosclerosis are much later. We don't talk here about the edema media thickness with IMT. Just for remembering different categories of patients, where you look to different numbers of scores, which going from 0 to 2,609 here, and remember the maximum is 10,000 score in those with renal disease. We can detect, see the distribution, and can quantify the disease of the coronary arteries. Sticks. I don't know why. The CT is generally very attractive for screening purposes because it is low-rate exposure of X-ray. That's risk-benefit analysis. It's very standardized, the analysis, due to Eggleston score analysis. It's so total time you need for analyzing is about 15 minutes. And we have a very high kappa value for interinstitutional variation. And that is a beauty. Calcium is a sign of atherosclerosis, and there's not a differential diagnosis which is different. So the possibility of scientific of recall study, and we needed a lot of time to get the funding, is something which is in epidemiology very rare. We put a question to the study. Is coronary calcium a sign of subclinical atherosclerosis? Improves risk prediction? And that was pre-specified and tried to be answered. We work in an urban area that's different to Framingham and others, with 1.5 million inhabitants. And the study, and that's also new, was certified and recertified according to ISO 9001-2000. Here you see now the results of calcium. 5-year event rate. In those without calcium, 0.9%. Extremely low. Remember the general population about 0.4%. So really below the general population. And when we go to more than 400, then you see the event rate is 8.3%. So higher than Framingham previously showed you in this slide. So a nice differentiation, and you see that the bars are not overlapping. That is something which is also very important to be known. We put our results in the publication of Dr. Greenland, which was the expert consensus document, and you see here the meta-analysis of him and our Heinz-Christoph Rico study. And I think it's a beauty that these analyses are nearly equivalent. And that is something which you rarely find from different methods. I think it's a unique feature of coronary artery calcification assessment. That's the Rotterdam study. It's the only other study in Europe running. They also looked in a different way to older people and did it 2 years earlier. And they came to cutoff values, as you see here, just below 100 and at about 600 as the cutoff values for low and high risk. I like to show this analysis of sensitivity and specificity. This was not shown and seen for other studies at the moment, I remember. And I looked here for ATP3 in our study. I looked for the calcium percentile distribution and calcium score. And I analyzed, I indicated here the positive predictive accuracy. And I think it is very astonishing that such a non-invasive method is coming to a positive predictive accuracy of about 13%. Remember, when you implant an ICD or defibrillator, the positive predictive accuracy is about 16%, 16, sometimes 20%, but not higher. And here's another method, non-invasively, to predict coronary events. I think a very important message. Here you see the results of MESA, and I put on the other side our results and demonstrate as MESA in a different way that calcium scoring is increasing the area under the curve by 0.51 versus 0.68 in the different studies. And please remember one study, MESA, announced the results, and the results of CT in our study were not known to the participants and physicians. I then took MESA the hard endpoints, because that is very important to have the same analysis, and here you see we came to an area under the curve of 0.749, and Dr. Brown published for Agatston score 0.66. That is something which has to do with the power, because we had more Caucasians, 4,400, and the MESA about 2,200. So it is really very important to see that this is working, and when you do analysis, it's interesting. If you look to segments of the coronary artery or calcium mass, it's not improving the results as well as looking to 75 percentile distribution, as ATP3 suggested. So what is the value for reclassification? You have heard of it. Here, another way shown, that when we look now to the population which we analyzed, that 14% were categorized as high risk, 60.9% as low risk. So really a big word and value of this feature. Now here you see the different way, 14.1 to high risk and 60.29 to low risk, and only 6.6% remained of the total population in the intermediate risk group. So a big advantage of the study using this analysis. And we looked also, as the MESA group and Dr. Patina from Framingham suggested, with the net reclassification improvement, 20.8% was our result, which is compared to other parameters very high. I'll show you later. And here you see the up and down classification, 20.8% for calcium scoring in parallel to Framingham risk. And of course you can widen the intermediate risk score from 6 to 20%, then we even get a net risk reduction improvement in 30.6% as a result. Just to show, of course, we also look to biomarkers, because many and funding of research is going to biomarkers, and we looked for CRP. That is the Dr. Whitaker's publication, Dr. Melly, where you see we have a relative risk of about 4 for the hair-sensitive CRP. In our study, we looked also for the high-sensitive CRP, and what you see here is between low and high risk, 4.1%, the lowest part compared to Framingham or compared to calcium have events. We did an analysis compared to calcium scoring, and interesting enough, we found a diagnostic value of high sensitive CRP in low risk categories, so 0 calcium. Here those with an elevation of high sensitive CRP had more events, and this was also true for women. The area under the curve is listed here, and you see again that when you add calcium, that then you get the highest value of 0.76 area under the curve. I think a very nice result. Again, up and down. Reclassification for sensitive CRP, 7.8% only, and it was not significant different. Here's a list of Mrs. Kone, which I have taken in order to add MESA, the Rotterdam study, and Heinz-Christoph Rico study, and you see that dependent on the definition, you come to a very high value for net reclassification, which is not seen for using diabetic categories, the high sensitive CRP, HDL, and even multiple biomarkers were not significant. Only in one study a difference could be shown, but not in this other analysis. And here the high sensitive CRP of our group is included, 7.8%, which fits not to previous publications who had a higher analysis but other definition of events. I want to end with one of the points which always stimulated me, and that is the events which occurred even in very important people. That is 2009 meeting in Davos, And you see that here Paul Wilson was listed, and you see that he was at this meeting. 14 days later, he died of an acute myocardial infarction. And in addition, at this meeting was Helmut Drexler, head of the Department of Cardiology in Hanover, and he died during exercise bicycle on a Sunday morning and could not be resuscitated, and not surgery went on but was not successful at the age of 58 years. So I come back to our problem. Problem is to identify those who are at high risk, and I cite here, as I told you before, Mrs. White, that Mason Sones, when he was in 78 in Frankfurt, the discussion was on fluoroscopy visualization of corneal calcium. That was the topic of the symposium. He said, so it seems to me that the most important problem we face is to find a way to recognize these people before they drop dead and tell us that they were sick. And I do hope that the new European guidelines, which at the moment for prevention and lipids are not including CT. In 2003 there was another guideline where they had advised some people to do it who are asymptomatic, but next year will come the new guidelines, and I've heard that calcium will play a major role then in this guideline. So in comparison to other signs of subclinical atherosclerosis, calcium scoring seems to be the method of choice for improvement risk prediction. And cardiology has to turn its attention to prevention, because here the biggest target for risk involvement has to be recognized, as the majority of patients, 60–80%, who die from MI, die outside the hospital and do not reach the hospital. And remember, in the general population, 10 times more people die from myocardial infarction than in those at high risk in our offices. 10 times more, 30,000 compared to 300,000 a year. And that is our task to fill. Thank you.